Thank you, and good evening, and welcome to the 20th J. Worth Ph.D. lecture of the Boston Medical Library. The Boston Medical Library was refounded. It had originally been founded in the early 19th century. It was refounded in 1875 by Henry Bowditch and his colleagues. And the first president was Oliver Wendell Holmes, with James Reed Chadwick, Dr. James Reed Chadwick, as the first librarian. It evolved into a large collection of antique medical books, including ancient manuscripts and hundreds of incunabula, books printed before 1500, and has been sponsoring this lecture for the last 20 years in honor of J. Worth Estes, who is professor of pharmacology and experimental therapeutics at the Boston University School of Medicine. I didn't know Dr. Estes, but he's described as a insatiable, passionate historian. And certainly his output in his very highly regarded books and papers convey that enthusiasm and
sorry guys.
The reports of people who worked with him report how infectious that enthusiasm was. He was editor of the Journal of History of Medicine and Allied Sciences. He was also treasurer of the American Association for the History of Medicine, and was a noted bibliophile involved with the American Antiquarian Society as an active member, and the Westwood Public Library, as well as the Westwood Historical Society. So he is a representation of passion and interest in the history of medicine. This is Dr. Estes. And this is the Estes Lecture Committee. I want to thank my colleagues on the Estes Lecture Committee for putting together this program tonight. We have a very special speaker, and that is sorry, a lot of technical issues here. Tonight we have Dr. Wangui Muigai, who is assistant professor of history, African and African American studies, and involved in the program in health science and policy at Brandeis University. And she is a graduate of Harvard College and Princeton, where she received her master's in art and Ph.D. And was a Woodrow Wilson scholar at Princeton. In 2017, she won the Shryock Medal of the American Association for the History of Medicine for her work on a fascinating documentary, All My Babies, and her beautiful explanation and explication of that movie is highly worthy of note. In 2022, she became a fellow, a Carnegie Fellow, and is also a faculty scholar in the Greenwall Faculty Scholar Program at Brandeis. And tonight her lecture is entitled "To Protect the Mother and Baby, Black Infant Mortality in a Historical Perspective," representative of her work on race, gender, and birth outcomes in children. And a very warm welcome. And I'm sorry about that rush there. We were a little close to getting on here. And thank you very much for joining us. I turn it over to you.
Thank you so much for that introduction. It's an honor to be giving the 20th annual J. Worth Estes Lecture on the history of medicine. And I want to thank the Estes Lecture Committee of the Boston Medical Library, especially the chair, Dr. DiMaria, for this opportunity to present. And thank you all for taking the time to virtually attend this evening. So I will start sharing my screen. Hopefully you can all see that. And as the title of my talk indicates, I want to offer a historical perspective this evening on race and infant death in America. And this sadly is not just an issue of the past, but one that remains a serious concern for medicine, for public health, and most of all for the families who experience the loss of a child. So with my time, I'll take us back to the 19th century era of slavery and move through to the early 20th century to examine the diseases, the health conditions, the social circumstances that have threatened the lives of Black infants. And throughout, I'll be drawing on a wide range of archives, in particular, highlighting the historical records where Black mothers, Black midwives, Black physicians living in the past described the challenges they faced in keeping babies alive and how they navigated those obstacles. And I'll conclude with some reflections on why I think knowing this history is important for us today. The past few years have witnessed growing attention to the nation's stark racial disparities in maternal and infant death. Available statistics show that Black babies and mothers are 2 to 3 times more likely than non-Hispanic whites to die during childbirth in the first year of life. Just a few weeks ago, the New York Times reported on a recent study conducted by a team of economists that found the birth outcomes for the wealthiest 20% of Black mothers to be similar to that of the poorest white mothers included in the study. Now, these findings are consistent with many other studies published in leading health and medical journals documenting racial disparities in birth across class, education level, insurance status, and region. And there are plenty of reasons to be alarmed by the data, especially given that childbirth is the most common reason women are hospitalized in the US. So to see such stark differences play out in outcomes is quite worrying. The situation is even more disconcerting when we place it in a broader context and take a longer view at where we've come in the fight to reduce infant death. Looking at this graph from the CDC, we see a dramatic downward trend in the infant mortality rate over the course of the 20th century. And the graph begins in 1915. This is when the US Census Office first began collecting information on births across the country, which made it possible to really capture the ages of the very young with more accuracy. At that time, President William Taft famously complained that government officials had a better sense of the number of pigs and the number of cows in each state than they did of the number of babies born. So officials developed a new document called the birth certificate and used posters like this to encourage families to fill them out. As officials began to report and record births across the country and infant deaths, they were shocked to find that well over 10%, or 100 babies out of every 1,000 died in the first year of life. From then, we start to see a dramatic decline in infant death rates that was brought on by the developments in modern public health, such as milk pasteurization, the development of sewage systems, which reduced the prevalence of water and milk-borne diseases that disproportionately killed young children. And medical advances also played an important role, including the invention and growing use of the incubator, as well as the introduction of sulfa drugs in the 1930s to treat bacterial infections like meningitis. But if we return to this graph, we see that by the 1950s, right in the middle, there's a leveling off, even some upticks in the infant mortality rate that came about because of new factors, such as more premature infants being delivered successfully, but dying within the first few weeks of life. Now, this slowdown really came as a shock to a nation that had witnessed such rapid progress in the prior decades, considered itself medically, scientifically superior, especially following the outcome of the Second World War. But when it came to infant mortality, the US had actually started to slip in its international rankings. from a respectable 6th place to 12th place by the mid-1960s. The Assistant Secretary of Health at the time publicly declared that America's losing battle to keep its mothers and babies alive was, quote, a disgrace. This was not only a serious public health issue, it was a point of political embarrassment, especially as countries like Cuba were starting to make headlines for reducing its death tolls. In the context of this tense and competitive Cold War climate, maybe many look to metrics like the infant mortality rate as a reflection of what kinds of government and healthcare systems better provided for its people. So following this 1950s stagnation, the decline in infant deaths really starts to pick up momentum again in the 1960s and 70s. And this was aided by the creation of new federal programs, such as Medicaid, that improved access to prenatal care, especially for America's poor, as well as the development of medical specialties like neonatology and obstetric anesthesiology that offer new tools and technologies like the APGAR score and neonatal intensive care units that helped clinicians better assess and address the health needs of newborns. Now, today, the infant mortality rate in the US hovers closer to 6 deaths per 1,000. And this remarkable reduction over the course of the 20th century has been described as a revolution, one of the most dramatic and far-reaching transformations in medicine and society. But I was struck by an aspect of this story that didn't really seem to fit this triumphant narrative. In fact, it really seemed quite troubling. And that was the question of why, through all these developments in medicine, in public health, in health policy, why has this blue line representing Black infant deaths remained consistently higher than the orange line representing white infant deaths? As I began to focus my research on this question, I realized I needed to look beyond the graphs, beyond the numbers, to understand the experiences of Black families, the challenges they faced in overcoming the conditions that have threatened their children's lives. And that sent me deep into the archives, traveling across the country to review a wide range of historical sources, really in an effort to reconstruct how those living in the past understood why Black babies died, what these historical actors did about it, and how families especially have coped with the loss of a child, because of course, behind every statistic is a baby that died. So in my effort to understand these individual family experiences underlying these numbers, I combed through family letters, I listened to oral histories, I read the memoirs of parents and midwives. These are the kinds of sources where I can hear and listen to people describing how they cared for a baby from its earliest moments of life through various health crises. These are also the kinds of sources, places where parents and caregivers express their grief. They discuss the struggles they faced in trying to keep young children alive. These accounts are difficult, they're heartbreaking to read, but bringing such stories to light is important for showing how profound the death of a child is. Its impact not only on parents, but also siblings, grandparents, and their communities. The matter of infant and child health has also long preoccupied the medical profession. And so a large part of my research has entailed looking through old medical journals, reviewing mortality reports, the records of public health departments and boards of health, to identify the challenges health practitioners and professionals have encountered when it comes to saving the lives of young patients. Through these sources, we can track how the leading causes of infant death have shifted over time, and how that shift has brought with it new opportunities as well as new challenges when it comes to caring for children. Another group of records that have been very valuable come from community organizations, institutions like newspapers and churches. And we don't typically think about these kinds of documents when reading or writing medical histories, but when looking at these historic efforts and struggles to keep children alive, to keep them healthy, to keep them safe, it's important to look at institutions like the church because they have long served as a trusted place families turn to for advice, for support when a child fell ill. So these are the kinds of perspectives that I've examined, that I've tried to delve into to really appreciate and understand how examining this history, really centering this history of Black infant death in America, can tell us a lot about the challenges African Americans have faced when it comes to their health and healthcare. And my exploration of these themes is part of a rich body of scholarship in the history of medicine that has illuminated the scientific theories, the clinical practices, the policies and political structures through which illness experiences like tuberculosis, like sickle cell anemia, how they've become associated with specific racial and ethnic groups. This research also really builds on the work of scholars like Judy Levitt and Charles Rosenberg, who've explored the ways that changes in how and where we give birth and get healthcare reveal broad transformations in cultural values, in our social relationships in the country. So as one example, this shift that took place over the course of the 20th century from giving birth at home, where a laboring mother was often surrounded by women she knew, to giving birth in a hospital where one is cared for by people who are essentially strangers, that is, attending physicians, nurses, residents that a patient has likely never met before. That has had a profound impact on how mothers and newborns experience the earliest moments of life. And as scholars, including Darlene Clark-Klein and the physician historian Vanessa Northington Gamble have shown, there's a long and rich tradition of Black Americans organizing to develop their own hospitals, their own public health campaigns, and their own nurse training schools in order to address the health needs of their communities. So to get at the roots of racial disparities in infant mortality, we really have to look at conditions and practices that were hundreds of years in the making. Dating back to the 18th and 19th centuries, the best estimates that we have indicate that between 20 to 25% of all babies died before reaching their first birthday. The rate was much higher for Black babies, especially those born enslaved, for whom over a third died in the first year of life. And that's a grim reality that families had to contend with, in which losing a young child was expected. It was almost unavoidable. So what made infancy really such a dangerous period of life? Babies faced many health dangers, and chief among them were infectious diseases like whooping cough and smallpox, with its telltale rashes and disfiguring scars. Other contagious diseases might appear at first as mild, but quickly turn fatal in young children. For example, a baby develops a sore throat. Now that could be a sign of just a common cold, or it could signal the onset of something much more deadly like diphtheria, which is a highly contagious respiratory disease. Many physicians refer to it as the strangler because it produces a thick membrane in the throat that makes it increasingly difficult to breathe and swallow. And the disease was especially fatal among babies and young children. Those who have small airways are more prone and liable to essentially suffocate to death. Now, looking across these leading and major diseases, these major causes of infant death, one of the most defining characteristics we see is that infant mortality in the 19th century really followed seasonal patterns. The numbers of death among all races always spiked in the summer months. This was when the warmer weather increased the chances of babies getting ill from contaminated water and milk that spoiled under the summer heat. These bacterial and viral infections would cause severe bouts of diarrhea and vomiting that were most fatal in small young children who lost significant body fluids and suffered from severe dehydration. Now, for families that had the means and the resources, they might leave their homes if an epidemic struck the area. They could spend the summer months elsewhere, places near a sea breeze or on higher elevation that were considered more salubrious, more healthy, where they could escape the threat of a contagious epidemic disease. But for the poor, for the enslaved, for those living in crowded quarters tied to their land, tied to their homes, that wasn't an option. These were the populations most vulnerable to getting sick and dying. And Black babies faced additional threats to their survival that stemmed from the brutal conditions of slavery, including the gendered violence and grueling labor demands that enslaved women bore and brought them in close and constant proximity to losing their children. And one of the most vivid examples of this comes from Harriet Ann Jacobs. Jacobs was born a slave in North Carolina in 1813, and as a young woman, she made a daring escape from her owners that involved hiding for 7 years in an attic so cramped that she couldn't even stand up straight. But from there, she was able to plan a really risky journey for her freedom, eventually making her way to Boston, where she wrote and published her life story in 1861, titling it Incidents in the Life of a Slave Girl. And this is one of the most well-known slave narratives written by a Black woman. Harriet Jacobs was owned by Dr. James Norcom, who was a highly respected physician who trained under Dr. Benjamin Rush. He received his medical training at the University of Pennsylvania. When Dr. Norcom opened his medical practice in North Carolina, he quickly became known for his obstetrical skills. Many white families called on him to assist them during birth. But when Harriet Jacobs became pregnant, Dr. Norcom was the last person she wanted to have attend to her. And that's because she had suffered years of violent abuse from Dr. Norcom and from his wife, Maria. And their vicious treatment of Jacobs intensified when she became pregnant. In her third trimester, she was critically ill. She was bedridden, but she adamantly refused to have Dr. Norcom attend to her because in her eyes, how could she trust the person who tormented her, who threatened her, who held her in bondage? How could she turn to this person and expect him to, quote, do no harm or injustice, as the Hippocratic Oath dictated? And she described this cruel irony in her narrative when she wrote, I could not have any doctor but my master, and I would not have him. So Jacobs then tells her readers, she writes about her harrowing experience giving birth, writing, when my baby was born, they said it was premature. It weighed only 4 pounds, but God let it live. I heard the doctor say I could not survive till morning. My master did not fail to remind me that my child was an addition to his stock of slaves. So here's a baby born early, low birth weight, in critical condition, and Jacobs herself was plagued by sickness for a year following the birth. As she made clear in her narrative, enslaved mothers not only had to endure painful and terrifying complications before, during, and after childbirth, if they interacted with white doctors, these were coerced, these were traumatizing encounters in which physicians like Norcom made it clear that they only cared about the survival of Black babies if it served their financial interests. Harriet Jacobs and her newborn son, they would go on to survive. But this intense fear, this proximity to death, the fraught nature of the doctor-patient relationship that she describes, this gives us a window into the struggles Black mothers faced in protecting their health and the health of their children. We get another fascinating perspective on these challenges from another rare source written by a Black woman. And this is from the words of Rebecca Davis Lee Crumpler, who was the first woman physician in the United States. Dr. Crumpler earned her medical degree in 1864 from the New England Female Medical College, which was the first school in the country to train women in medicine. It was located in Boston, and when Crumpler studied there, it was in the South End neighborhood. Crumpler came into medicine with a lot of prior experience, working as a family nurse, and also being raised by an aunt who tended to the sick in her Philadelphia community. So in choosing to go to medical school, Crumpler forged a way to deepen her expertise and continue providing care to poor Black families, especially mothers and babies. After graduating from the New England Female Medical College, she moved from Boston all the way up to Canada. And while she was there, a devastating cholera epidemic swept through the area. Crumpler devoted her practice, her attention to caring for the local Black community there. The families that she tended to, they told Crumpler that doctors rarely visited the area, that the white physicians who were willing to attend to the Black community were, quote, few and far between. She describes all this in a book she published in 1883, titled A Book of Medical Discourses. This was the first medical text, the first health guide written by an African American, and in it, Crumpler offered over 100 pages of maternal and infant healthcare advice, which she explained, quote, that her chief desire in presenting this book is to impress upon somebody's mind the possibilities of prevention. Alongside this advice, which she directed to mothers, Crumpler also wrote about the obstacles that poor and working class Black mothers faced in trying to protect their baby's health. She wrote in her book, quote, the laboring women of my race appear to work under heavy disadvantages. And the challenges that Crumpler pointed to are many of the same ones we face today. Factors like racial discrimination, trying to find a decent place to live, to secure work that paid good wages and would allow parents to support their families, and the struggles Black families faced to live in an area where they had access to nutritious food and clean water supplies. Crumpler witnessed firsthand the devastating impact of these factors on Black infant survival. After helping the Black Canadian community through the cholera epidemic of 1865-1866, she decided to move down to Richmond, Virginia that year. Now, this was just as the Civil War had ended. Richmond was the capital of the former Confederacy, and Crumpler felt called to bring her doctoring, her healing skills, to help the thousands of African Americans living there who were now free and completely on their own. So it's worth recognizing that she's part of this first generation of Black medical professionals who understood early on how central the issue of maternal and infant healthcare was for their communities. She was on the ground in Richmond in the makeshift camps where newly freed African Americans lived, and there she was delivering babies, she was training midwives, she was helping mothers so that families could survive and make it through all the calamity and all the uncertainty of the Civil War and its aftermath. Those struggles to improve and to bring health and healthcare to Black communities intensified with the rise of Jim Crow in the 1870s, a long period during which states and local communities legally enforced racial segregation, denied Black Americans their full rights as citizens by restricting their movements, their opportunities, their access to public resources. Racism and legalized segregation were deeply entrenched across the country, impacting all aspects of life. And as with all other institutions that operated under a Jim Crow logic, healthcare followed the color line. Many white physicians refused to treat Black patients, and those that did might only see Black patients on certain days of the week or at certain times after white patients had been cared for. Dr. Haley Tanner Dillon Johnson, who was one of the first Black women physicians to practice in Alabama, wrote about how white doctors were known in her area to charge Black families for each mile they had to travel to reach patients, and that physicians demanded to be paid in cash and upfront before they offered any treatment. Now, for poor Black families, many of whom worked on farms as sharecroppers, they had little access to cash. So calling on a doctor, that wasn't an option. That wasn't something that was realistic. They relied on midwives, on women healers who had long stood as pillars in their community and who were trusted for their skills in maternal and infant care. In her memoir, detailing her decades of care, the decades of care she provided in rural Alabama, the midwife Oni Lee Logan described that in the areas where she practiced, doctors were not an accessible or reliable option. As she explained, when you call on one, even if you call one today, he might come tomorrow. He might come tomorrow. It was the midwife or nothing. Now, for Black laboring women who needed emergency or hospital care, the few white hospitals that did admit Black patients treated them horribly. They placed them in awful areas like a damp basement. These were segregated wards that housed all Black patients, irrespective of their medical needs or the contagious nature of their illness. So this meant that when in hospital settings, Black newborns, Black mothers were vulnerable, more vulnerable to preventable complications and substandard care that could result in premature death. So it's one thing to look at the physical access that Black patients had to hospitals, and it's another to look at the quality of that access, right? Like what's actually happening, what kind of care is being made available in hospitals in other medical settings. One study published in the American Journal of Public Health found the number of women who died from pregnancy-related causes to be, quote, excessive. The health officer conducted a 5-year study of maternal deaths in Alabama and found that physicians' errors were 50% more frequent in Black obstetrical cases. So this is what Black mothers and babies were up against in hospital settings. We can understand more deeply the way these structures impacted Black families, their experiences of infant death, when we look to the life of Mary Church Terrell. Mary was born to enslaved parents. She grew up in Memphis before going on to earn her bachelor's and her master's degrees from Oberlin College. She had a remarkable life and career. She was an educator, public speaker, a writer, an activist, committed to racial equality and women's suffrage. But before much of her career and activism in this work really took off, she, her husband, Robert, were living in Washington, D.C. They were trying to start a family. And it was a painful journey. In her memoir, titled A Colored Woman in a White World, Terrell offers a glimpse into this experience, writing, "In 5 years, we lost 3 babies, one after another, shortly after birth. When my 3rd baby died 2 days after birth, I literally sank down into the very depths of despair." So when I first came across Terrell's memoir, I was really struck by this passage, by how she briefly described this tragic period of her life. And I wanted to know more. I wanted to know more about what happened, what she went through in these long 5 years. And that took me deeper into her archives. It's worth noting that Mary Church Terrell has a remarkable archive. It's preserved and stored across multiple institutions, including the Library of Congress. And in looking through her diaries, the letters she sent and received from different family members, even the early drafts of this memoir she would publish in 1940, a more tragic story emerges, one that really sheds light on the challenges Black women faced in giving birth, the options they had, and the people they turned to for care and comfort. During her first pregnancy, Mary experienced severe bouts of vomiting and weakness. She had a miscarriage in her 8th month. And doctors believed it was caused by Bright's disease, what today would likely be diagnosed as kidney disease. They assured her that many other women with the same condition had gone on to have a healthy birth. She was shaken by this loss, but still encouraged, and 3 years later, Mary found herself pregnant again. This time, she placed herself on a strict diet. She cut out meat. She vigilantly monitored her health in the hopes that she could avoid another tragic end. That was not to be the case, and her second pregnancy ended in stillbirth. By this point, a strong network of Terrell's friends and families had stepped forward to provide the devastated couple with support. Mary's father, he rushes from his home in Memphis to be by her side, and Mary's mother ends up whisking her away to Saratoga Springs, New York, so she could recover in a more therapeutic setting. When Mary found herself pregnant for the 3rd time, she and her husband decided to enlist the help of not 1, but 2 physicians when she went into labor. She gave birth to a son, but complications arose, and he died 2 days later while still in the hospital. And in the memoir she would write, Mary described how this loss really cut deep. It caused great pain and anger, writing that right after its birth, the baby had been placed in an improvised incubator. And I was tormented by the thought that if the genuine article had been used, its little life might have been spared. So even as the Terrells were among the very privileged, they were part of the Black elite. They could afford private medical care. The color line, racial discrimination, and segregation still held firm in the nation's capital, regardless of one's means. And Mary would never get over the fact that because of her race, she and her baby could not be admitted into a hospital equipped with the most sophisticated technology available at the time. So when Mary was pregnant for the 4th time, she decided that she needed to leave Washington, D.C. and get care elsewhere. She traveled to Philadelphia in her 3rd trimester, and she may have been drawn to the city because of its history of providing women-centered care, as well as its strong network of Black doctors and nurses, including those affiliated with the local Black hospital there, Frederick Douglass Memorial. Mary Terrell made the short journey from D.C. to Philadelphia, and there, in 1898, she gave birth to a healthy girl named Phyllis. The Terrells were relieved. They were overjoyed to welcome their daughter. Yet they still bore the scars of their earlier losses. It wasn't even until Phyllis was 2 weeks old that the parents were willing to share the news of their daughter's birth with their closest family. Now, by the turn of the 20th century, right when Mary Terrell is struggling to have her baby survive, there was a growing belief among the public and health professionals that the death of an infant was not inevitable. It was not something that individual families like the Terrells had to suffer through. Rather, infant mortality was increasingly seen as a national problem, something that could be prevented. And this belief was in part informed by new understandings of disease causation. Doctors and public health officials drew on the laboratory experiments of Louis Pasteur, Robert Koch, and others to educate the public, especially mothers, about the importance of adopting new kinds of practices like hand washing and giving infants milk that had been pasteurized as measures that would help stop the spread of deadly germs. Luther Emmett Holt, who was one of the country's leading physicians, pediatricians, explained in 1913 that most infants who died, quote, were healthy at birth, merely the victims of a bad environment, improper feeding, and neglect, conditions which it is quite possible to remove. So Holt was not alone in believing that the diarrheal diseases, the respiratory illnesses that had long reigned as the major causes of infant death, could now be effectively combated through new public health measures and bacteriological knowledge. The central message of this campaign to reduce infant mortality was the idea of saving babies. This call to save the babies was part of a broader concern with children's welfare that shaped progressive politics and health welfare in the World War I era. It appeared throughout newspapers, even in government publications, as we see in this poster here, portraying babies as the wealth of the nation. The government's commitment to infant health reached a new height when President Woodrow Wilson declared 1918 to be the Children's Year, and he set aside a portion of wartime funds to support a year-long campaign of infant and child welfare activities. As part of this effort, officials from the U.S. Children's Bureau worked with a wide network of women-led volunteer organizations to establish prenatal clinics, build child health departments, distribute free health pamphlets, and host film screenings. And the response to the campaign was tremendous. More than 11 million women organized and participated in these events. But health officials implemented most of these events and programs in white and European immigrant neighborhoods. Black communities were ignored, they were segregated, they were excluded from participating on equal terms. In addition to these barriers to access, the white medical profession largely regarded the health of Black people as inherently inferior, impervious to intervention. Such entrenched practices and ideas meant that even as Black and white infant deaths went down, they remained apart as health officials were quick to blame Black communities, to pathologize their behaviors, instead of addressing how the very structures of Jim Crow racial segregation reinforced and perpetuated the health disparities they were seeing. So in the face of this widespread discrimination and racism, Black Americans developed a number of initiatives within their communities that brought needed resources and services to mothers and their children. They pursued several strategies to combat racial discrimination in healthcare and to demonstrate that the higher rates of infant death in their communities reflected social, environmental, economic inequalities. They were not rooted in inherent biological differences. Black women led much of this work through community-based organizing that recognized how factors like poverty and literacy impacted health. So they hosted health film screenings, they made posters so that individuals across literacy levels had an opportunity to learn modern techniques of infant care and hygiene. They organized health clinics that took place in community institutions like the center pictured here in Detroit. There, the local chapter of the National Urban League sponsored well baby clinics for infants to receive a free checkup from local Black doctors and nurses. Now, these checkups are going to evolve into the type of routine child visits that are now an integral part of pediatrics practice. Such opportunities for professional medical care served a critical need for Black families who might not otherwise be able to afford it. And for migrants newly arriving from the rural South, this could very well be the first time that they're interacting with a physician. Recognizing that the kind of care babies received was largely shaped by economic circumstances, Black women also established nurseries for working mothers to be able to have a safe and supervised place where they could leave their babies during the day. And on this slide, we see another example of the kind of grassroots work done in Black communities. It's a little known initiative, but something that was very popular at the time called Little Mothers Clubs. This is where young girls attended weekly classes taught by healthcare workers, where they learned how to prepare a baby's milk bottle. They learned ways to keep a home clean, to sanitize, to open windows to allow for good ventilation. All of these lessons were intended to educate girls on how they could help take care of their younger siblings, especially if their parents worked outside of the home. And Little Mothers Clubs, these were popular across different racial and ethnic communities. But this was a period when nearly a third of married Black women worked, compared to just about 6% of married white women. So the idea and this need for educating Black girls in modern infant care was especially important. They were likely the ones put in charge of watching over their siblings. Now, by far the most important institution for carrying out Black maternal and infant care work in the early 20th century was the church. Health professionals like the nurses pictured here used Black churches as the basis for a lot of the prenatal clinics, a lot of the health outreach that they did. And this made sense on many levels. Black ministers, churchwomen, their congregations, they knew well those who were in need of support. And in the Jim Crow South, the church was one of few Black-owned spaces. It was a space that was largely spared and protected from white intrusion and attack. Now, alongside these community-based efforts to improve health and healthcare resources, leading Black social scientists of the time, like W.E.B. Du Bois, conducted painstaking research to demonstrate that the higher rates of premature death and disease in Black communities had no basis in biology, but were rooted in social, economic, and political conditions. And the tragedy of losing a young child, this hit close to home for Du Bois. In 1899, his firstborn son, Burghardt, came down sick with fever. And that ended up being diphtheria, that feared strangler of young children. For days, Du Bois and his wife, Nina, tried to find a doctor who was willing to treat him. When Burghardt died, it devastated the young parents. It was a painful period that Du Bois wrote about in his acclaimed work, The Souls of Black Folk. And at this point in his career, Du Bois had conducted a groundbreaking sociological study of African Americans in Philadelphia. For that research, he went canvassing door to door, surveying the living conditions in Black neighborhoods, combining his firsthand observations with careful statistical analyses. The data he gathered exposed how practices of racial discrimination, housing discrimination, forced Black Philadelphians to live in the most unsafe, most unsanitary, and the most unhealthy neighborhoods. And in marshaling all of this evidence, Du Bois argued for the importance of recognizing the man-made factors that shape health outcomes, what today we more commonly refer to as the social determinants of health. He followed up his 1896 study with another, published under the title The Health and Physique of the Negro American. For this, Du Bois again drew on multiple data sources, including census reports, hospital statistics, and mortality data from institutions like life insurance companies to present a diverse portrait of Black health. And here again, Du Bois sought to challenge and refute arguments that Black people were inherently more susceptible to disease and premature death. As he argued in his report, the high infantile mortality of Philadelphia today is not a Negro affair, but an index of a social condition. Much of what Du Bois called for in these early studies remain relevant to contemporary research in racial health disparities, especially the ways in which he demonstrated that health disparities were inextricably linked to other forms of inequality, and is a critique of scientific theories that argued racial groups have inherently different health and disease experiences. These were the same factors that Dr. Rebecca Crumpler pointed to in her work, writing about race and infant health in 1883. So when we look at this early history, spanning the mid-19th century into the opening decades of the 20th century, you can better understand the unique challenges Black families have faced in trying to safeguard their infants from sickness and death, and how deeply rooted those obstacles are, especially when it comes to accessing quality care, accessing and securing living and working conditions that promote rather than threaten the lives of women and children. Through educating their communities, marshaling needed healthcare resources, even sharing their personal stories of loss, Black parents, Black medical professionals, and Black health activists have chosen not to remain silent, but to speak out about the unjust life chances that they and their children face. We are still studying, we're still documenting and debating the disadvantages that Crumpler, that Terrell, that Du Bois outlined in their works published over a century ago. And that says a lot about how far we still have to go in creating a healthcare system and society that truly supports the health and well-being of women, children, the poor, the marginalized and vulnerable. At the same time, there are some signs of change. We can look, just one example, to the Black Maternal Health Omnibus Act, the legislative package first introduced in 2020 by Congresswoman Alma Adams and Lauren Underwood, and then California Senator Harris. When she became vice president, Harris continued to elevate this issue of more funding and more research to better understand and address the disparities in the higher rates of Black maternal and infant death. And she called on federal officials to do more in addressing this as a national priority. In our current moment, when there's so much debate over why the US has higher rates of infant death than other developed countries, it's worth remembering that Black leaders and their communities have long worked to raise awareness of this issue. They've drawn attention to the ways in which they bear a heavier burden of sickness and death that for too long has been rationalized as natural or the fault of individuals, rather than a tragic reflection of an unequal and inequitable society. They've left behind a rich legacy of community-based work, reflecting a deep commitment to health equity that we cannot afford to overlook if we are truly invested in making childbirth safer in this country and ensuring that every baby born is given an equal opportunity to live. Thank you.
Thank you for a wonderful, wonderful presentation. We have questions in the chat or in the Q&A, and the first question comes from Dr. Shamir. About 1 to 1.5 generations separate the social efforts to improve hygiene in the 1910s and 20s, antibiotics in the 40s, civil rights in the 60s and 70s. Which of these events did the most to impact outcomes?
That's a great question. Thank you. And that returns us back to that earlier graph and narrative I offered in terms of taking that long and broad view of sort of where we've come in this fight to reduce infant deaths in this country. By far, we see that the most noticeable and dramatic advances really came from a lot of these basic public health measures like sanitary conditions in cities and urban areas, these basic improvements to the living conditions that take time to spread across regions and rural and urban areas across the North and the South did a lot to not only improve infant and child health and well-being, but just the basic standard of care and survival for Americans across the country. From there, with the development of vaccines, of antibiotics, that brings another level of success and advances in terms of really combating and tackling these major infectious and contagious causes of disease. These are not things like whooping cough, diphtheria. These are not major causes of death today. Today, parents are much more likely to be concerned about conditions like sudden infant death syndrome, babies born with low birth weight who are premature. So that's reflecting a new epidemiology of infant health and infant death. And so that's sort of how I think about it when I'm looking at all of these broad transformations and developments that have come across these generations and the ways in which they've impacted infant health in this country.
The interventions that are being proposed now in terms of addressing infant mortality and disparities in infant mortality are the kinds of things that we would like to think Massachusetts was leading in terms of assuring that people have access to health care, that they have access to prenatal care, that the babies get the best possible care, and sort of things that have been done to an extent in Massachusetts. Yet in Massachusetts, Black babies have twice the infant mortality of white babies, despite what we think of as doing the kinds of things that should be done nationally. So how do we interpret that?
Yeah, it's a very complex issue. And I think, in part, if the focus is on prenatal care, if the focus is on the care that women receive from the prenatal period onward, I think that's already too late, right? So the kinds of conditions and constraints and things that can support or really erode one's health and the ability for one to carry out a healthy pregnancy and have a baby survive are factors that are well in place before the 9 months of pregnancy. So Boston is, I think, a really interesting and important example, because here we have, such a high concentration of hospitals, of medical institutions, of centers for care for maternity and obstetrical care. And as you know, these disparities still persist in this city, in this state. And so that means that thinking only in terms of access to medical professionals, access from the prenatal to the postpartum is not enough to really address and tackle some of the roots of these disparate outcomes. And I think that's something where it's really important to not only have clinicians and healthcare providers who are thinking about solutions and opportunities for addressing this, but also those who are involved in broader public health measures and community organizing, who really understand the living and working conditions of families, of people who are trying to build a family, and can help identify whether it's access to food, whether it's transportation needs, whether it's environmental conditions in terms of pollution, what else is happening in people's lives, in women's lives, and birthing people's lives that is attributing to the outcomes that we continue to see today.
Dr. Feldman says, thank you for an incredibly powerful presentation. And related to social determinants, do you think that racism explains why the early identification of social determinants were not incorporated for so long? The things that were identified by Du Bois and by people like Lillian Wald and very, very early on, but somehow we never translated.
I think, thank you for that question. And, I'm looking at it now as it's typed, and it says, why has, the social determinants of health only recently become identified as important? And for me, I think, identified by who? Because the families and the practitioners that you see in these archived documents and these historical sources, even, in spaces like the Children's Bureau, where they're conducting the first early investigations of infant mortality across the country in the 1910s, they're paying attention to the earnings that fathers make. They're paying attention to the living conditions in tenement housing that families have. They're paying attention to, do mothers have access to indoor plumbing, to toilets? These determinants of health have long been recognized by public health leaders, by families, by social workers. It doesn't take on this category in the way that we sort of hold up that term and might, know that it encompasses a lot. But this understanding that there's so many social factors that impact one's health and one's illness experiences, not just based on a germ or a virus or a bacteria, I think the historical record speaks to how widely that has been understood. And it really then just becomes a question of whose responsibility is it to address these, to improve these determinants, to work on these social determinants in the service of improving the public's health.
And then next question is, would training more Black obstetricians help improve the disparity?
So that is something that a recent study in the fall of 2021 actually reported something quite striking, where it showed that for Black newborns, this was a study looking specifically at births in the state of Florida, about over a million births, and found that for Black babies who were delivered and attended to by Black physicians, their survival rate was much higher. I think something on the order of about 50% higher, their survival rate. The same was not, that same correlation was not found when it came to maternal deaths and maternal outcomes, but the researchers did find this particular difference when it looked at Black infant survival. So there was, that did bring up this question again of, should we be thinking about practitioners? Should we be focusing and investing on things like racial concordance? Should we, continue, and we should, to work to diversify the medical profession, to make sure that those who do want to pursue a career in the health professions have, the opportunities and access to get that kind of training and that kind of expertise? I think that is all important. That is not going to completely do away with these disparities that we see. This isn't just, again, about what's happening when a laboring woman shows up at the hospital if she chooses to give birth in a hospital. But that study, I think, really does bring to light, the question of, again, what kind of care is being made available? And why do you see such consistent patterns depending on the care team that women have? This might relate to the ability for patients to feel as if their needs, their desires and choices when it comes to their birthing options, when it comes to medication, when it comes to surgical interventions like a C-section, are either being respected, they're not being rushed over, that any kinds of complaints that might be arising while hospitalized are taken seriously. And so those are very critical, that those can be real moments that determine whether a mother and or baby make it through, make it out, and make it home alive. But that is not the only space where we're seeing these disparities, where we're seeing these critical issues, where we're seeing such differences in outcome. So it is important to continue thinking about, the training of medical professionals, the kind of care that's being delivered, the kind of care that patients experience and receive. But that is, and that is one part of the larger picture.
Then a question from Dr. Alperin about Arlene Geronimus's book, Weathering. And could you speak about how this concept of weathering might impact pregnancy?
Sure. So in Arlene Geronimus's decades of work and research, she has really worked to theorize and to demonstrate the ways in which these factors, these social factors, these assaults of racial discrimination, of racism, of gendered racism that Black women experience, how this impacts the body, how this, leads to an accelerated kind of aging that can result in the earlier incidence and higher likelihood and higher prevalence of complicating health conditions, of premature birth, of babies born with low birth weight. So her research, that's really, her conceptualizing of this idea, weathering, is, I think, a really powerful way to think about the experience of giving birth as a Black woman in America, where, she is trying to understand and document and trace from, a physiological perspective, the impact of stressors on the body. But it's also a sense in this idea of weathering in the ways that Black women have endured, they have organized, they have found ways to cope. Some are not healthy, some are healthy, some are affirming. And so her work is really looking through a lot of these complexities that stretch beyond and stretch before, rather, the pregnancy period, really looking from a life course perspective on how a lot of the determinants and the factors that I had touched on can really embody and impact Black women and have an effect on their reproductive health.
Dr. Muigai, thank you so much for a magnificent Estes lecture. I can't but imagine that Dr. Estes would be delighted and would have enjoyed this and been as impressed as we are by your very powerful message, and thank you so much.
Thank you.
And this ends our program this evening. Thank you all for attending, and stay tuned for more from the Boston Medical Library. And good night.